Hi there, my name's Graham Finney. I'm one of the anaesthetic registrars based at Glasgow Royal Infirmary, and this is a short talk on emergency drugs. This is for the GRI Nurse Education series, but would be applicable to new anaesthetic trainees as well. So there's some stuff I'm going to touch on that's applicable to both. And if you just look at your own learning outcomes to judge whether or not things are necessarily relevant to you or not. So what we're going to talk about is emergency drugs that we use both in theatre but also that are used in intensive care units as well. So what are we going to cover? So I think ultimately probably the most important thing is that you need to really have an understanding of the physiology behind why people are hypotensive, because ultimately we're talking about the emergency treatment of hypotension to ensure that we continue to maintain a cardiac output. So understanding the physiology will help you to understand what it is you need to try and fix in order to improve that cardiac output and improve the patient's blood pressure ultimately. So we'll talk about things that put your heart rate up. We'll talk about things that help your heart pump well. And we'll talk about things that squeeze your blood vessels. So essentially, I mean, your cardiovascular system is just a fancy plumbing system, like you're heating at home. In order for you to pump hot water into your radiators and things, you need to have a pump that works, ideally that gets serviced fairly regularly, isn't in terrible condition, and you've got to have blood vessels that are of an appropriate diameter that go where they need to go and aren't clogged up with mess that they don't want to be clogged up with. So let's talk a bit about the physiology, because ultimately understanding this makes understanding what the drugs do a lot more straightforward. So we've got some equations to look at, and these may be things that you've seen before, but essentially blood pressure is equal to the cardiac output multiplied by the systemic vascular resistance. The cardiac output as a concept is basically the amount of blood, so the volume of blood that your heart pumps out per minute. Okay, and if you ever think about that, it's really obvious. It's basically the stroke volume, which is the amount of blood that your heart pumps out per beat, so the volume in mils that your heart pumps out with every time it beats, multiplied by the number of times it beats in a minute. Okay, so that gives you the volume of blood that your heart pumps out in a minute. Okay, and for the kind of average 70 kilogram man at rest, that's somewhere in the region of about 5 litres. It's 70 mils per kilo is your resting cardiac output. So that changes whether you're big or small and whether you're exercising or not and all these sorts of things. So therefore, if you substitute the cardiac output equation, so heart rate times stroke volume, into our original blood pressure equation, you get heart rate times stroke volume multiplied together times the systemic vascular resistance is equal to the blood pressure. So it's important to understand how these things interact. And so your blood pressure is a dynamic system. Okay, so I'll just focus on this a little bit, but that equation is obviously quite simplistic, and ultimately you're dealing with a dynamic system. So increasing the heart rate will only improve the blood pressure up to a point. Increasing the systemic vascular resistance will only improve the blood pressure up to a point. Okay, and really pushing the contractility or the stroke volume of the heart will only increase the blood pressure up to a point. What I mean by that, so heart rate, in terms of your your heart, it's only perfused during diastole. So the left side of your heart, anyway, is only perfused during diastole. Systolic time is a fixed time. Usually it's not particularly manipulatable, but diastole is dependent on your heart rate. So if your heart rate is lower, then you have a longer time in diastole, and because of that, you then have a longer time to perfuse your left ventricle. So if you increase your heart rate, you begin to shorten your diastolic time. And if your patient's young and fit and is used to cycling or running marathons or something like that, then they'll be used to that. They'll be used to dealing with higher heart rates. But if you've got an old crumbly patient who's got ischemic heart disease, they're a bit more they've got less physiological reserve to deal with a higher heart rate. And if you decrease the amount of time during which you're perfusing the left side of the heart, then you run the risk of causing ischemia. Similarly, if you increase your systemic vascular resistance beyond which the heart is able to cope with, then you're ultimately increasing the amount of work that the heart is having to do. So by increasing your systemic vascular resistance, you're essentially increasing your afterload. So that increases the amount of oxygen that your heart is having to use to contract against. It's increasing the pressure against which the heart has to contract. So again, you increase your myocardial workload, which with time will start to decrease as the heart basically becomes tired. Working against that, your stroke volume will fall, and as you can see from the equation, if your stroke volume starts to fall, then you drop your blood pressure. So it's not quite as simple as X times Y times Z equals blood pressure. These things all it's a dynamic system, and you need to consider the patient in front of you and how these things might interact. You might want to go away and look at Starling curve, is it Frank Starling curve as well, as to why increasing their stroke volume might then too far essentially, and increasing their end diastolic volume might end up having a negative impact on the stroke volume. But that's kind of possibly beyond the scope of this talk for some people. So we'll have a wee look now about the receptors involved. So we're talking about the sympathetic nervous system for the most part, but a little bit about the parasympathetic nervous system. So adrenal receptors are the main receptors of the sympathetic nervous system. There's three main ones that we're particularly interested in. There is also alpha-2 receptors, but I'm not going to touch on them in this talk. So alpha-1 receptors, beta-1 receptors, beta-2 receptors. They're all located in different areas of your body, and they do different things. So alpha-1 receptors are mainly located on your blood vessels, and activation of them results in vasoconstriction. Then you have two types of beta-1 receptors. There's beta-1, beta-2. They're the main ones that we're considering here. There's an easy way to remember where they are. So beta-1 are located in your heart because you have one heart. Beta-2 are located in your lungs because you've got two lungs. Okay, so the main action of beta-1 receptors is both to speed up the heart rate and increase the contractility. Beta-2 receptors are predominantly bronchodilators. Activation of them can cause an increase in your heart rate as well, but that's the main clinical action of them. And the last thing we need to consider is muscarinic acetylcholine receptors. So they are part of your parasympathetic nervous system, beg your pardon. And the action of the parasympathetic nervous system is to rest and digest, and that involves your heart rate decreasing. So activation of those causes a decrease in your heart rate. So therefore, if we inhibit them, then we can get an increase in the heart rate. And we'll talk about that. So, all these things that we've talked about, we can start to fill into our, we can kind of flesh out this equation a little bit, and kind of by looking at this slide, you can start to see where, if you were to invent some drugs to do different things, you can see where different receptors then have their action to increase the blood pressure. The things that are in green, activation of those causes an increase in your heart rate, stroke volume. So basically a positive effect for what you're looking at. The muscarinic acetylcholine receptor, that's in red, because if we want to increase the heart rate, we need to antagonise it, and so inhibit its action. So we'll talk a wee bit about, I'm going to touch on this and start to flesh it out a wee bit more as the talk goes on, but there are kind of, in a day in theatre, there are sort of standard emergency drugs that we draw up and are appropriate for the majority of patients. So these are atropine and glycopyrrolate, which are antimuscarinic drugs, and ephedrine and metaraminol. And we'll cover these in a wee bit more detail in the following slides. Obviously, occasionally we have to bring patients to theatre who are really, really sick, and for them, we think about drawing up things like adrenaline, noradrenaline, and if in certain patients we might consider something like dobutamine, although you'd see that used more in cardiac centres like the Golden Jubilee. Okay, so this next slide starts to fill in the gaps a wee bit, and the colour coding system here, I've tried to use the drug labelling system or something akin to the drug labelling system that we use in theatre. You'll also notice that some of the drugs are in bold and some of them are in not bold. Essentially the reason for that is that these are drugs that might do the same sort of thing. You can see that a lot of the drugs work on the same receptors, but not all drugs are created equally. A sort of analogy that I try to use is if you consider there are certain drugs are like diet versions of others. So like taking metaraminol, for example, metaraminol is like a diet version of noradrenaline, which is like full fat Coke. But from the chart you can, and same goes for atropine, glycopyrrolate, and adrenaline and ephedrine. So taking atropine and glycopyrrolate, for example, giving a dose of that creates they both increase the heart rate, but whereas glycopyrrolate you get far more of a gentle increase in heart rate. Something like atropine, you get a pretty marked tachycardia after it. So it's a lot more of a potent effect, a lot more of a dramatic effect. And it's again, it's about just choosing the right drug for the right patient. The one thing that we haven't talked about is fluid as an emergency drug, and it's a really important emergency drug. If you have a hypovolemic patient, particularly a severely hypovolemic patient, then no amount of, or you're potentially doing harm to patients by kind of giving high doses of things like adrenaline or noradrenaline if you haven't ensured that the patient's euvolemic at least close to euvolemia before and as part of your resuscitation process. So so the stroke volume, the amount that the heart puts out with each beat is dependent on both the amount of blood that is in your left ventricle at the end of diastole, which is dependent on your preload, and how well your ventricle contracts. So moving on now to drugs that increase heart rate. So we've already looked at this in the last equation, but just to kind of cover it in a wee bit more detail. We've got, these can be kind of grouped into two groups. So ones that act on the parasympathetic nervous system and ones that act on the sympathetic nervous system. Atropine and glycopyrrolate are antagonise the parasympathetic nervous system, so they are antimuscarinics or anticholinergics, you might hear them getting called. So essentially the parasympathetic nervous system tries to slow down the heart rate and the action of atropine and glycopyrrolate antagonises that. The main kind of clinical difference between them in terms of heart rate that it produces is atropine produces a much more marked tachycardia than glycopyrrolate, which is a lot more quote-unquote gentle. Now, these you need to take into account your patient as well. Young, fit people will tolerate a marked tachycardia much more than an old crumbly person with ischemic heart disease. So that needs to be taken into consideration. Obviously, the higher the heart rate, the higher the myocardial oxygen consumption. The other thing to say is that atropine can cross the blood-brain barrier, so older people in particular, it might cause them to be confused. So in clinical practice, we tend to kind of use glycopyrrolate when to sort of gently speed up the heart rate when it's a little bit on the low side and your blood pressure is a little bit on the low side. Atropine tends to be reserved for almost like an ALS type situation where the patient is severely bradycardic and hypotensive, particularly once your heart rate, in theatres anyway, we tend to use it when the heart rate gets down into the mid to low 30s. The other three drugs are act on beta-1 receptors, so ephedrine, adrenaline, dobutamine. Ephedrine's a particularly interesting drug in that it has both direct and indirect action. So direct in that it will have a direct agonism or cause direct agonism of beta-1 receptors, but it also causes endogenous release of adrenaline and noradrenaline. So you get an indirect action on that. So I should say ephedrine acts on both alpha and beta receptors, but just in the context of this slide, we're talking more about beta receptors. It does exhibit something called tachyphylaxis, and tachyphylaxis is essentially a reduction in response for the same dose of drug repeated over and over again. So what that means is essentially you give a dose of ephedrine and it does something, and then 2 minutes later you give another dose of ephedrine and it has a similar effect but not quite as much, and then the effect reduces the more and more doses you give. In part that's to do with using up the endogenous stores of adrenaline and noradrenaline. Adrenaline obviously speeds up your heart rate. In this context, it's by beta-1 receptors. Dobutamine also does the same. Interestingly, dobutamine also reduces your systemic vascular resistance, so it really it makes the heart pump harder, pump quicker, but also reduces the afterload against which the heart is pumping. Adrenaline and dobutamine, particularly as the dose increases, it can be associated with arrhythmias. They're pretty arrhythmogenic drugs, so these all need to be taken into consideration and really given by people who know what they're doing. Next, let's talk about drugs that increase stroke volume, and again you're noticing some of the same drugs. So these three drugs, not only do they increase the heart rate, but they increase how hard the heart pumps, so the contractility. Okay, so dobutamine is not a drug that we particularly use in general practice quite so much, but particularly in cardiac centres or people with left ventricular systolic dysfunction, like a poorly functioning left ventricle might need a bit of help. You always need to take into consideration the increased myocardial oxygen consumption with making a bad ventricle work harder. But yeah, all these three drugs acting on beta-1 cause the heart to pump harder, increase blood pressure. So again, just going over drugs that increases systemic vascular resistance. So that's basically how constricted your arterial tree is. For the most part, these drugs all act at alpha-1 receptors, with the exception of vasopressin, which is antidiuretic hormone, which acts at vasopressin type 1 and type 2 receptors, so V1, V2 receptors. It's a potent vasoconstrictor. The main difference between the main thing with vasopressin is it doesn't act particularly on the pulmonary circulation, so you don't get a massive increase in pulmonary arterial systolic pressure with it. So the rest of them all act at alpha-1 receptors, metaraminol, noradrenaline. I've not included phenylephrine in this list, but you'll see that used a lot in the maternity unit, and in some units outside the west of Scotland, phenylephrine is the vasopressor of choice over metaraminol. I've kind of divided them up a wee bit into ones that are purely work, or for the most part, purely work at alpha-1 receptors. Adrenaline obviously acts at alpha-1 receptors, but also beta-1 and beta-2. The same goes for ephedrine. And vasopressin, we've already discussed, acts in a different way. These are particularly useful in vasodilated patients, and this is really the case. This is where you would choose to use a drug that increases systemic vascular resistance. The most common reasons for being vasodilated are either that you are under a general anaesthetic, so general anaesthesia causes a reduction in your systemic vascular resistance, or septic shock would be the most common reason in the intensive care unit. And what you're aiming for is to try and return their arterial tree to some kind of normality. Obviously, you can over-constrict, and if the patient has a bit of a compromised left ventricle especially, then it doesn't deal very well with over-constriction, because what you're then doing is you're making that heart work harder against an increased resistance, and you might actually see that your blood pressure drops despite you putting up your SVR and putting up your metaraminol or your NORAD. And the reason for that is because the heart can't generate pressure against that, so your cardiac output actually drops. And if you go back to the original equation, your blood pressure is equal to your cardiac output multiplied by your systemic vascular resistance. So clearly, if you drop your cardiac output, or an increase in your SVR to the point where it drops your cardiac output, they'll start to offset each other, basically. I thought I'd just include this slide just about other drugs to consider. So you can go and read about these in your spare time. They act, some of them act the same, some of them act differently to the kind of mechanisms we've already discussed. As they're more kind of, some of them are involved in increasing your blood pressure through the mechanisms we've talked about in terms of your stroke volume and in terms of your systemic vascular resistance, and others are used more as emergency drugs, for example adenosine in treatment of SVT. But I'm not really going to go into much more detail than that. So we'll just finish up by really going over this whole thing again, because I think if you understand this slide, this is the kind of crux to at least understanding the basics, and taking it from here you can start to think about the way all these things are going to interact with each other. You can start thinking about in what circumstances, how to choose your emergency drug, basically to increase or to improve the patient's blood pressure. What is it that is essentially causing them to be hypotensive? Is it preload? Is it that they're not filled enough? Do I need to give them fluid? Is it that they're really bradycardic and hypotensive? Is it that their stroke volume is not where it needs to be? They've got a known history of left ventricular systolic dysfunction? Or are they deeply anaesthetised or septic, and do we need to bring up their systemic vascular resistance, which in turn will help improve their coronary perfusion? Again, just reminding you that the kind of ones in bold are the more potent, or the kind of full fat versions of the drugs which are not in bold, and all those are the receptors that they work at. So if you really if you learn this slide well, then hopefully you'll kind of understand the rest. So in summary, just managing hypotension is all really about understanding the underlying physiology. That's key to this really, and working out why is the patient hypotensive. Usually if you can figure out why the patient's hypotensive, then at least picking your drug becomes an awful lot of an easier process. Understanding the physiology helps to understand the pharmacology, and obviously what we've spoken about, working about the underlying problem, will help with drug choice. I hope this has been useful. I know there's been a wee bit of babbling in it, so apologies for that, and a bit of verbal diarrhea, but obviously the beauty of this is you can go back and listen to it again, and hopefully after a couple of times it all might start to make sense. Okay, thank you.